Hi, everyone. My name is Samir Parekha. I'm at Mayo Clinic in Rochester, and I take care of patients with CLL. A lot has changed in the field of CLL in the last many years, and I think as a clinician, it is heartwarming to see that our patients are doing better. They have more treatment options, and they are living longer. And my goal in the next 40 minutes or so is to share what we've learned over the last many years with respect to treatment options in patients with CLL, both in the frontline setting as well as in the relapse refractory setting. And I think the way this presentation has been structured is we will start with the young, quote unquote, fit patients in the frontline setting, then the older adults in the frontline setting, and then finish it up with relapsed CLL. So this is a background of how treatments have evolved over the last many decades in CLL. And as you can see, the top sort of part of this slide reflects the treatment changes that have occurred in the 60s through the early 2000s. And certainly we've made a lot of changes over the years, but the bottom slide really demonstrates the power of what has happened in the past decade, particularly since the approval of ibrutinib in 2014 for relapsed CLL and a slew of small molecule inhibitors that have come in the market and have been approved for the treatment of both primary or frontline CLL as well as in the relapsed refractory setting. And I think going forward, 2023 and beyond, you will see on your right that there are additional medications that are likely to receive approval, including novel BTK inhibitors such as zanubrutinib and pirtobrutinib, potentially CAR T-cell therapy, and maybe other PI3 kinase inhibitors. And so I think as we think about the progress that has been made, I think ultimately at the end of the day, in front of our clinic in the patient setting, I think we need to make sure that we apply these evidence accurately to be able to treat the patients well. And so, over the last many years, we've always considered FCR as our sort of backbone of treatment, consisting of fludarabine, cyclophosphamide, and rituximab in the young fit patient population versus bendamustine and rituximab or chlorambucil-based treatment in the older adult patient population. However, things have changed in the targeted therapies era in the last decade or so, where we no longer consider FCR as a frontline sort of treatment of choice in the young fit patients. And targeted therapies really has taken over our frontline treatment approach. You could still consider FCR in young, fit, mutated IGVH patients where there is no evidence of high-risk features such as del17P or a TP53 mutation, although as we will see in the slides ahead, even in this group of patients, targeted therapies appears to have a better outcome. And so this is one sort of suggested treatment approach for the standard treatment of CLL in the frontline setting. I think it is important to remember that despite all of these improvements that have occurred in the treatment options, patients who do not meet IWCLL criteria for therapy at the current time still should be observed. There is no reason to treat them early. There are ongoing clinical trials that are testing early intervention in high-risk CLL patients, but until those trials show a demonstrable improvement in patient outcomes, we should still wait for patients to develop symptoms, have progressive lymphadenopathy or splenomegaly, or have some other typical cytopenias, which would constitute the IWCLL criteria for starting therapy. And then if a patient is treatment naive, the first thing to do is to look for the presence of deletion 17p or TP53 mutation. And I think this is important because, as you can see, that based on whether the patient has this high-risk marker or not, treatment paradigms are different. I'd like to point out that you should do both a CLL FISH panel that looks for deletion 17p and a next-generation sequencing or a Sanger sequencing study that looks for TP53 mutation, because about 5% patients will actually harbor a TP53 mutation in their CLL cells in the absence of deletion 17p by FISH. And if you don't do both these studies, you'd actually miss on that group of patients that actually have a TP53 mutation. If there is evidence of this abnormality, then on your left, you will see that what is preferred is a BTK inhibitor-based treatment approach in a continuous fashion, either ibrutinib or acalabrutinib with or without obinutuzumab. Venetoclax plus obinutuzumab is a possibility as a treatment option in this group of patients, although the PFS in cross-trial comparisons appears to be shorter compared to continuous BTK inhibitor-based treatment, and therefore most of us would actually choose continuous BTK inhibitor-based treatment in patients who have this high-risk aberration. And then if patients don't have a TP53 mutation, and if they are younger, have mutated IGV8 genes, you have a variety of treatment options, including FCR or any of the other 3 targeted agents. If they have unmutated IGV8 status, typically we would not consider the use of chemoimmunotherapy in this group of patients. And then on the other hand, if a patient is older and has major comorbidities, again, none of the chemoimmunotherapy treatment options appear there, and any of these novel agents would be appropriate. And then all of these agents would also be appropriate in the relapse refractory setting on the far right, assuming a patient has previously received chemoimmunotherapy. So these are the FDA-approved treatments: ibrutinib, acalabrutinib, and venetoclax and obinutuzumab. The difference between these 3 is that venetoclax and obinutuzumab is the only time-limited treatment approach for 1 year, whereas the others are continuous treatment options. And then, like we talked about, it is expected that zanubrutinib will receive FDA approval this year, and then potentially even the combination of ibrutinib and venetoclax as a time-limited approach, which was tested in major phase 3 studies. And so these are the NCCN guidelines. As you can see that first-line therapy, there is no mention of chemoimmunotherapy as preferred regimens. All of these treatment programs that are referred here as preferred regimens are all novel agents, including acalabrutinib, venetoclax, and potentially even zanubrutinib once it is approved by the FDA, but it is already listed on the NCCN guidelines. And then there are a variety of other recommended regimens that you could use. And then even in the second and subsequent line of therapies, it's all BTK inhibitors and BCL2 inhibitors that are used for the management in CLL. So diving into the data, what about young fit patients and frontline therapy? So this is a major phase 3 study called the E1912 study that was done by the ECOG group led by Dr. Tate Shanafelt and colleagues. And in this study, patients who were less than 70 years of age and did not have deletion 17p by FISH were randomized in a 2:1 fashion to either ibrutinib and rituximab or to FCR. FCR was given in a standard fashion for 6 cycles, and ibrutinib and rituximab was given where rituximab was administered for 6 cycles and ibrutinib was given continuously until a patient had disease progression or intolerance to therapy. And the initial results from this study showed that therapy with ibrutinib and rituximab was associated with superior progression-free survival, as you can see over here, where at 5 years, roughly 1 in 5 patients did not have any evidence. Only 1 in 5 patients, I should say, had evidence of disease progression, compared to about 1 in 2 patients with FCR where there was progression of disease noted, suggesting that continuous ibrutinib-based therapy in the young patient population really was associated with superior outcomes. Interestingly, at the more recent update that was published last year in Blood, on your left, you will see that patients who had unmutated IGV8 genes, which is a so-called high-risk subgroup of patients, there was a difference in the PFS. But in addition, even in the favorable subgroup of patients with IGV8 mutated genes on your right, you will see that there was an improvement in progression-free survival with a p-value that was statistically significant. And so again, although you could continue to use FCR in the young, fit, IGV8 mutated patients without the presence of deletion 17p, these data actually suggest that even in this favorable risk group of patients, novel agents, and particularly ibrutinib and rituximab, as was shown in this trial, is associated with superior outcomes. And in my practice, I've moved away from using FCR in even these very small cohort of fit patients who might be eligible for FCR, because I believe that this treatment with ibrutinib and rituximab or any other novel agent-based therapy would likely yield better outcomes. Interestingly and importantly, there was also an overall survival benefit seen with the use of ibrutinib and rituximab. Very few studies in the frontline setting actually are able to demonstrate an overall survival improvement, and here you can see that although it's a small difference, it is statistically significant again, showing the power of novel agents in the frontline management of young fit patients with CLL. A similar study was conducted by our colleagues in the UK called the FLAIR study, where patients received an identical combination of ibrutinib and rituximab, and this was compared to FCR. I'd like to point out that in contrast to how we give FCR here in the United States, FCR is given slightly differently, where fludarabine and cyclophosphamide are administered orally. But essentially, the treatment schema is pretty much the same, and patients received oral ibrutinib daily until disease progression or until intolerable toxicity. And a total of 771 patients were enrolled in this study, and they were randomized 1:1 across both these arms. Patients who actually had more than 20% nuclei that had a TP53 deletion or a deletion 17p were excluded. And so there is a small cohort of patients where they may have a fewer percentage of TP53 deletion that were allowed on study. And again, this is not surprising. Similar to the E1912 study, you will note here that the patient population that received ibrutinib and rituximab, had a superior progression-free survival compared to FCR, again, showing the power of novel agents in the management of frontline CLL patients compared to standard therapy with FCR. Here on your left, you will see that in the high-risk subgroup of patients which are unmutated IGVH, again, there was a demonstrable benefit with the use of ibrutinib and rituximab, although in the mutated IGVH subgroup, there does not yet appear to be an improvement in PFS, and this may change over time with longer follow-up. As of now, there is no difference in the overall survival between these two groups of patients that received ibrutinib versus FCR. And these are important differences between E1912 and the FLAIR study. Some of the differences may be explained by the patient population. So for example, here, deaths in the FCR arm predominantly were secondary malignancies, Richter's transformation, and infection, whereas deaths in the ibrutinib arm were really predominantly related to cardiovascular related and non-hematologic malignancies. Now, in contrast to E1912, where the vast majority of deaths in the FCR arm were because of progressive CLL, which is maybe one of the reasons why we saw a difference in the overall survival between FCR and ibrutinib rituximab in the US study, the E1912. Regardless, I think this speaks to the importance of subsequent line of therapies that our patients may need once they progress on chemoimmunotherapy, if that's the route you chose to give your patient treatment with. Another important thing to remember is the cardiovascular toxicity with ibrutinib and rituximab. Here you will see that patients who received ibrutinib-based therapy had an increased risk of cardiovascular events, particularly those who had a history of hypertension previously. And again, this is an important reason to look for this toxicity that can happen in older patients who have a history of hypertension, valvular heart disease, or any arrhythmias in the past. And in that group of patients, continuous BTK inhibitor-based treatment can be associated with significant toxicities. So what about time-limited treatment options in this group of patients? So here is a phase 3 study called the CLL13 or the Gaia study led by Dr. Eichhorst and the CLL study group from the Germans. And this study was presented last year at 2 years ago now at ASH, and updated data were presented at EHA, where fit patients who did not have any evidence of TP53 mutation were randomized into one of 4 different study groups. So in the top, patients would get either FCR or VR, or they would get venetoclax and rituximab, or they would get venetoclax and obinutuzumab, or they would get a triplet of venetoclax, ibrutinib, and obinutuzumab. And this was a 1:1 randomization for all these 4 groups, with the primary endpoint being undetectable MRD at month number 15, or a PFS at that time point. A total of 920 patients were enrolled. And as you can see over here, patients who had received any obinutuzumab containing regimen, which is this column here which says GV, which is venetoclax and obinutuzumab, had a superior undetectable MRD status at 86% compared to patients who received chemoimmunotherapy. And patients who received the triplet treatment had a MRD undetectable rate of 92%. And so these were both superior to chemoimmunotherapy. Now, this is one of the first studies that actually compared head-to-head the use of rituximab and venetoclax to obinutuzumab and venetoclax. And you can see that the rate of undetectable MRD is significantly higher with the use of obinutuzumab. This suggests that patients who receive obinutuzumab in conjunction with venetoclax likely will have better outcomes. And typically that is the antibody that we have now begun to use in combination with venetoclax for all our patients that need treatment. Now, an important question to look into is, does this translate into better outcomes? And in fact, it does. So you will see here that patients who received venetoclax-containing regimens with obinutuzumab, which is GV, which is venetoclax and obinutuzumab in pink, and black, which is the triplet regimen, had superior progression-free survival compared to patients who received rituximab and venetoclax or chemoimmunotherapy. There was no difference in patients who received venetoclax and obinutuzumab, whether they got ibrutinib in the black curve or not, at least right now with current follow-up. And so the role of triplet therapies in CLL is still being considered and discussed. But certainly these data point to the fact that obinutuzumab is associated with a superior progression-free survival in combination with venetoclax compared to rituximab and venetoclax. Longer follow-up will certainly give us more information about how this will pan out over time. What were some of the adverse events? It is not surprising that patients who received chemoimmunotherapy with FCR and VR had a higher risk of infections and febrile neutropenia. But I'll also point your attention to the far right column where patients got triplet therapy with obinutuzumab, ibrutinib, and venetoclax, where the risk of infections was similar to chemoimmunotherapy. And again, this is an important thing to remember. And then one more thing to point out is the risk of hypertension, which is a BTK inhibitor class effect, where you see that patients who received the triplet therapy that contained ibrutinib, actually there was a higher risk of hypertension compared to chemoimmunotherapy or any of the venetoclax-containing regimens. And so these three studies, actually the E1912, the FLAIR study, and the Gaia study actually tell us the powerful nature of novel agents, including BTK inhibitors and venetoclax-based time-limited combinations compared to chemoimmunotherapy, and really suggest that they should be used in the frontline management of CLL patients. What about older patients with CLL who need treatment? So this is the RESONATE-2 study that took about 269 patients and treated them with either ibrutinib or chlorambucil. Patients with deletion 17p were excluded from this study. And this is a standard 1:1 randomization. And again, this is no surprise that patients who received ibrutinib did much better compared to chlorambucil. And these are data that are demonstrate the 5-year progression-free survival with the use of ibrutinib in this older patient population. Now, the question really was, okay, well, chlorambucil is not the best comparator to ibrutinib. And so what about bendamustine and rituximab? And so here are data from the Alliance study led by Dr. Jen Voyach and colleagues that actually showed that actually tested a 3-arm study where bendamustine and rituximab was compared to ibrutinib, which was compared to ibrutinib and rituximab. Again, BR was given for a standard of 6 cycles, and ibrutinib was given until disease progression, and IR was given in the same schedule as the E1912 study. Importantly, patients who had progression of disease on BR were allowed to cross over to ibrutinib at the time of disease progression. And so again, here, these data are very instructive and show the superiority of continuous ibrutinib-based treatment in both the blue and the pink curves compared to the purple curve with BR, and show that after a median follow-up of about 55 months, either ibrutinib-containing regimen was associated with a longer PFS. An important point to remember here is that rituximab did not improve the PFS. The addition of rituximab did not improve the PFS, and therefore typically, if you use a BTK inhibitor, I have not combined it with rituximab when I use ibrutinib. Instances where I really combine a BTK inhibitor along with an anti-CD20 monoclonal antibody treatment are when I really need a faster response, meaning if a patient has a very high white count, or if a patient has autoimmune hemolytic anemia, or has glomerulonephritis, or other sort of tissue infiltration of CLL where I really want faster disease response. Those are the places where I'll really combine a CD20 antibody, but otherwise I'll just use a single agent BTK inhibitor because that does not appear to be a significant difference in PFS. And so, as we've all learned and heard about the potency and the selectivity of BTK inhibitors, you've all seen these graphs where the kinome map of second generation BTK inhibitors looks like they are better compared to ibrutinib. And so acalabrutinib and zanubrutinib are both being developed. Acalabrutinib is approved. Zanubrutinib is likely to get approved for CLL soon. And so what are the data that support the use of acalabrutinib? This is the ELEVATE-TN study where patients were randomized, again, in a 1:1:1 fashion to 3 arms with acalabrutinib and obinutuzumab compared to acalabrutinib alone, compared to chlorambucil and obinutuzumab. And patients with deletion 17p were actually allowed on this study, but patients who progressed on chlorambucil and obinutuzumab were allowed to cross over to single-agent acalabrutinib. And here are data from the ASCO and the EHA update in 2022, where you will note that patients who got either acalabrutinib-containing regimen had a superior progression-free survival compared to chlorambucil and obinutuzumab. But interestingly, you will note that about 12% patients actually have a improvement in PFS with the addition of obinutuzumab to single-agent acalabrutinib. So we don't know whether this really is an effect of obinutuzumab or the BTK inhibitor. But remember, with ibrutinib, the addition of rituximab did not make a difference, whereas here we are actually beginning to see a statistically significant difference in PFS at 5 years with the addition of obinutuzumab. So this might actually sway people's mind in adding obinutuzumab to patients who you're considering to begin single-agent acalabrutinib treatment. This is in patients who received these treatment program in patients who had deletion 17p. There was no difference in the PFS between patients who received single-agent acalabrutinib or the combination of acalabrutinib and obinutuzumab. So it would appear that you can easily do just single-agent acalabrutinib in patients who have deletion 17p. And again, this treatment should certainly, chlorambucil and obinutuzumab should not be used in patients who have deletion 17p. So what about zanubrutinib? So this is the Sequoia study where patients were randomized 1:1 in this cohort 1 to either zanubrutinib as a single agent or bendamustine and rituximab, and patients with deletion 17p were excluded from this study. And it is again not surprising to see that patients who received zanubrutinib did better compared to bendamustine and rituximab, much like the Alliance study. And this data will likely lead to an approval for zanubrutinib in the frontline setting. What about fixed duration venetoclax or obinutuzumab in the frontline older patient population? So these are the results from the CLL14 study, and these are the 5-year updated data. And just as a reminder, the CLL14 study compared venetoclax and obinutuzumab for a total of 12 cycles of treatment. So every patient stops treatment after 12 cycles of treatment compared to chlorambucil and obinutuzumab. And again, the primary endpoint here was PFS. These are the baseline characteristics of the patients. About 216 patients are randomized to each of these 2 arms, median age of about 72 years. And you can see that the vast majority of patients actually had intermediate risk TLS category, and about 2/3 of these patients across both treatment arms. Importantly, both the treatment arms had a median estimated creatinine clearance of over 60, which was one of the requirements to participate in this study because of the risk of TLS with venetoclax. Additionally, patients with deletion 17p were allowed in this study, and about 7 and 8% in the chlorambucil and the venetoclax arms were patients who had this high-risk aberration. And these are the 5-year updated data. They indicate that patients who received venetoclax and obinutuzumab had a superior progression-free survival compared to chlorambucil and obinutuzumab. which is again not a surprise, but speaks to the power of this combination therapy. Now, I'd like to point out that here, this vertical line, which says the end of treatment, is the 12-month time point. And so all of the gain that you see on the right after the 12-month time point really reflects the ability of patients to stay off treatment yet not have progression of disease. Another important point to point out is that although a patient may have progression of disease after the treatment is ended, that does not necessarily mean that the patient needs to start treatment right away, because many patients will have asymptomatic lymphocytosis or slight increase in their lymph nodes, and that would not automatically trigger the need for additional treatment. And so the time to next therapy is again much longer compared to the progression-free survival numbers that you will see here. I'd also like to point out that again, cross-trial comparisons with the Resonate-2 study or the CLL 13 study, or even the study with Elevate-TN and the Sequoia study, they all seem to indicate that the PFS at the 4 or 5 year mark in the frontline setting appears to be equivalent, suggesting that you can choose any of these treatment options in a patient that you feel is appropriate for these treatments. And certainly the patients seem to enjoy a good PFS regardless of the type of novel agent that you've used in the treatment. Now here is breakdown of PFS according to the IGVH status, and you will see that patients who had mutated IGVH status had a much longer PFS compared to those with unmutated IGVH status. This is again not surprising, because patients who have high-risk features with unmutated IGVH genes are more likely to have faster progression of disease. And here is the PFS curves for patients with TP53 mutation, and you will see that patients who have this in the solid blue line have a PFS that is a median of about 4 years or 49 months. This is in contrast to BTK inhibitor-based treatment, where with acalabrutinib single agent, you saw that at about 5 years, this was 71% PFS. And so again, cross-trial comparisons, but BTK inhibitor continuous therapy appears to be superior from a PFS perspective compared to time-limited duration therapy with venetoclax and obinutuzumab for this high-risk deletion 17p subgroup of patients. There was no difference in overall survival between the two groups of patients, likely as a consequence of crossover that was allowed in the study. Now, what about MRD? And so, measurable residual disease or minimal residual disease is becoming an important aspect to consider in our patients. At the current time, we don't really have any data that suggests that changing our treatment approach based on MRD status is important, but it is really a very powerful prognostic indicator, meaning if you're able to get MRD negativity, it is likely that your patient will have longer progression-free survival compared to a patient who does not achieve undetectable MRD status. And here you can see that after 4 years, roughly 1 in 5 patients has sustained undetectable MRD status, which is obviously much better right after a patient completes therapy. But this speaks to the fact that patients who are able to achieve MRD negativity and maintain that status for a longer period of time continue to experience durable remissions. And here is a PFS curve, which actually shows that the NGS profile that is really available through clonoSEQ for us to detect MRD status in these patients reflects that 10 to the power minus 4, either through NGS or clonoSEQ or through a flow cytometry-based MRD assay can actually detect this threshold of 10 to the power minus 4. And you can see that patients who have achieved a more than 10 to the power minus 4 MRD negativity have a superior progression-free survival compared to these patients who do not achieve undetectable MRD status. So what about some of the side effects? Well, I think it's important to remember that tumor lysis syndrome remains a concern in this group of patients, but during treatment, only about 1.5% patients experienced laboratory tumor lysis syndrome. None of these patients actually achieved or experienced clinical tumor lysis syndrome, which is an important thing to remember. I think this speaks to the fact that these patients who come for venetoclax and obinutuzumab treatment have to come on a weekly basis for the first 9 weeks as they begin this treatment. The first 3 weeks, a single agent obinutuzumab and venetoclax is added in week number 4, at 20 milligrams, and then they step up on a weekly basis up to 400 milligrams over the course of the next 5 weeks. If you follow the package insert guidelines, etc., the risk of TLS on this protocol, and again with many real-world studies, is exceedingly low. Of course, you need to give your patients allopurinol and give them adequate hydration, etc. But those are all things that are standard and routinely done. Another important side effect of this combination of treatment is leukopenia, or in particular neutropenia, and that was seen in a substantial number of patients here, although the risk of febrile neutropenia was about 3 to 5%. We've liberally used growth factor support such as Neupogen or pegfilgrastim when we treat these patients during the step-up dosing for venetoclax to try and maintain the schedule of venetoclax, yet deliver Neupogen or Neulasta to maintain a normal white count. And once patients get through the dose escalation phase of venetoclax, we are able to continue with the venetoclax at 400 milligrams, which is the target dose. In some patients, we've also run into diarrhea as one of the important side effects, and again, that can be managed by dose reduction of 300 or 200 milligrams of venetoclax. So here are some of the pros and cons of each of these major treatment approaches that are available, and I think this sort of reflects the surfeit of riches that we really have in the field of CLL in the frontline setting, where you have on the one hand ibrutinib with the longest follow-up available, and a next generation BTK inhibitor with acalabrutinib with reduced off-target effects. But both of these need to be given for an extended duration of time. There is no stopping these treatments once you start a patient on these treatments. And of course, these come with the side effects of atrial fibrillation, bleeding, etc. Whereas on the right, venetoclax and obinutuzumab is really a time-limited approach of treatment with high undetectable MRD rates. But again, some of the difficulties that we talked about are early on that you need to see the patients on a weekly basis, etc. And the fact that patients with deletion 17p, this might not be a suitable treatment approach. And so the way to choose between one of these treatment approaches is really talking to your patient, identifying what are some of their preferences, and then looking at their comorbidities. So if a patient has hypertension, has a history of bleeding, has a history of AFib, is on anticoagulation, etc., I think that would really sway me in looking at venetoclax as a treatment option. On the other hand, if a patient really has renal side effects or has renal dysfunction, then I would really think about doing a BTK inhibitor-based treatment approach and choose either ibrutinib or acalabrutinib. And because of some of the head-to-head study that have shown acalabrutinib to have lesser side effects compared to ibrutinib, even the NCCN guidelines now recommend that you choose a second-generation BTK inhibitor, such as acalabrutinib, when you're going to choose a BTK inhibitor in the treatment of CLL. So that was a whirlwind tour of frontline CLL. I'd like to spend the next few minutes talking about relapsed CLL. And so this is the original sort of study that led to the approval of ibrutinib, called the RESONATE study. And this is patients with heavily pretreated CLL who either got ibrutinib as a single agent or they got ofatumumab, because back then ofatumumab was really approved in patients who had progressed after multiple lines of therapy with CLL. And again, crossover here was allowed if patients had progression of disease on ofatumumab. The median prior number of therapies was 3, and these are the updated data published now 3 or 4 years ago in the American Journal of Hematology, and you will see that treatment with ibrutinib in this heavily pretreated patient population, the median PFS was almost 4 years, compared to ofatumumab, which was about 8 months, and a number of patients crossed over to the other side and received ibrutinib. And this really established ibrutinib as one of the first-in-class agents that really changed how relapsed CLL patients were managed. I referred briefly about this head-to-head comparison of acalabrutinib and ibrutinib. This was an open-label study where patients got either acalabrutinib or ibrutinib in a relapse refractory setting, and patients were stratified according to the presence of deletion 17p. Only those patients with 11q deletion and 17p deletion were allowed in this study, so a high-risk relapse refractory CLL patient population. And the primary endpoint really was to look at non-inferiority in PFS between these two agents, and then look at a variety of secondary toxicity endpoints. And so these data here show that both of these agents, acalabrutinib and ibrutinib, are equivalent with respect to efficacy. You can see that the curves are overlapping, and there is a median PFS of about 38 months. Median prior line of therapy here, I believe, was 2. And so again, this shows that both of these agents are equally good to be used in the management of relapsed refractory CLL. However, there were important differences in the toxicity profile between the two drugs. And again, you will note that here patients with ibrutinib, more patients with ibrutinib experienced atrial fibrillation, bleeding, and hypertension, along with this possible increased risk of interstitial lung disease. And so this really points to some of the adverse events that appear to be more likely with the use of ibrutinib. In contrast, patients with acalabrutinib who received acalabrutinib, those patients had a higher risk of developing headache, and that's sort of one of the more common side effects with acalabrutinib. What about the Alpine study? Now, this is a recent study that was presented by Dr. Brown and colleagues at ASH last month. And here, it was a similar study design. It was an open-label study where patients got either zanubrutinib or ibrutinib. And in this study, unlike the Elevate-RR study, all comers were allowed, meaning there was no risk stratification or no eligibility with respect to the CLL FISH profile. And patients with prior BTK inhibitor therapy were excluded to participate, and this was a major phase 3 study. And the primary endpoint in this study was the overall response rate, which in a single-agent BTK inhibitor-based trial we now know is not very meaningful. But here you see the PFS differences that were presented last month, and you can see that treatment with zanubrutinib was actually associated with the superior progression-free survival compared to ibrutinib. Now, there are many questions about this, whether the ibrutinib arm underperformed, etc. But at the end of the day, what these data suggest is that both these agents are actually quite they work very well in the setting of relapsed CLL, but potentially because of a different kinome profile, because of a different tolerability profile, maybe zanubrutinib is better compared to ibrutinib. And again, similar to the Elevate-RR study, here you will see that there are many differences in the side effect profile between zanubrutinib and ibrutinib, particularly with respect to the risk of atrial fibrillation, where you will see that the risk of atrial fibrillation with zanubrutinib was about 5.2% compared to 13.3% with ibrutinib. Interestingly, there was no difference in the hypertension rates between the two groups of patients, and there was no difference in the neutropenia rates, except maybe a slightly higher risk with zanubrutinib, which I think we've all come to appreciate. What about non-BTK inhibitor-based treatments for relapsed CLL? So this is the Murano study that was led by Dr. John Seymour and colleagues, where patients with relapsed refractory CLL were treated with either venetoclax and rituximab compared to bendamustine and rituximab. Patients received venetoclax for a total of 2 years, and all patients stopped treatment at 2 years. So in contrast to CLL14 in the frontline setting, where patients got venetoclax for 1 year, in the relapsed refractory setting, patients receive it for 2 years, and then they stop treatment. And then after BR, if a patient has progression of disease, they were allowed to cross over to venetoclax-containing regimen. And here are updated data that were presented last year in the JCO journal, where you will see that really BR should never be used in the relapsed refractory setting, particularly if a patient has received chemoimmunotherapy in the past, because the median PFS was about 17 months. In contrast, with venetoclax and rituximab, the PFS was about 5 years, which is far better. And again, I'll point out here that patients stop treatment with venetoclax at the 2-year time point. And so all of this PFS advantage is really where patients are off treatment. Additionally, there is also an overall survival benefit seen with the use of venetoclax and rituximab compared to bendamustine and rituximab, suggesting that it is important to use venetoclax sooner in the relapse setting compared to BR in this patient population. An important caveat to remember in this study is that none of these patients, or a very small number of these patients, had actually previously received ibrutinib or any other BTK inhibitor. And so we have to be careful drawing conclusions from this study to a patient you may be seeing in the clinic who is now having progression of disease on ibrutinib or acalabrutinib. We don't really know if the PFS benefit of 53.6 months as a median with venetoclax and rituximab is really achievable in that patient population or not. And certainly we need additional data to be able to inform that group of patients. What about MRD? Again, much like the frontline setting, PFS really at the end of treatment was determined by the end of treatment MRD status, where patients who did not achieve undetectable MRD in the red had a faster progression of disease compared to those in green who had undetectable MRD. And there is this intermediate category of MRD called as low MRD, where the amount of CLL present is between 10 to the power minus 2 and 10 to the power minus 4, and those patients do intermediate and they are in between. Again, this is a powerful prognostic test at this time. It does not really tell us that we should change treatments based on what we see as an MRD result at the end of treatment. So what are some of the limitations? I mean, I think we've heard about adverse events. There are resistance mechanisms being developed with the cysteine 481S mutation, PLC gamma 2 mutation in patients who are on BTK inhibitors. And in BCL2 inhibitors, now there are emerging data of BCL2 mutations that may drive resistance in part to venetoclax-based treatment. And so that's really where the next generation of treatments, including pirtobrutinib, which is a covalent BTK inhibitor, comes in. And these are data presented by Dr. Mato and colleagues at ASH 2022. So on your left, you will see the kinome selectivity. And if you remember the kinome map that I showed you of the other 3 BTK inhibitors, this appears to be much more specific to BTK. This is a covalent inhibitor, and in xenograft models, it is as efficacious in killing CLL cells as ibrutinib is. And it is actually much better in the BTK-resistant cell lines with the C481S mutation, which is one of the most common mutations that occurs when patients receive ibrutinib-based treatment and have progression of disease. And here you can see that in a total of 247 patients that were treated, the overall response rate with the use of pirtobrutinib as a single agent was remarkable at 82%. Much like every other BTK inhibitor, the rate of complete remission was low, but the partial remission rate was impressive at 71%. And you can see the waterfall plot with a vast majority of patients experiencing improvement in their disease status. Importantly, it's also notable that 100 patients had actually received both a BTK inhibitor and venetoclax prior to getting on this study. And even in that very high-risk subgroup of patients, the overall response rate was pretty impressive at 79%. And these asterisk marks actually indicate patients who had received a prior BCL2 inhibitor. What about the safety of this drug? It's early. You can see that the median time on treatment at this time is about 9.5 months. So we can't really be, as dogmatic as we can be about some of the other BTK inhibitors. But it does appear that this drug is very well tolerated, and discontinuations due to treatment-related adverse events really occurred in a handful of patients. And this is very, very good to see. Importantly, the adverse events of special interest, including atrial fibrillation, hypertension, bleeding, etc., that were grade 3 or above, were actually in single digits. And this is really important and impressive because one of the things that everyone worries about is this a class effect of hypertension and atrial fibrillation? At least at this early time point, it appears that this drug is quite safe with respect to some of these adverse events of special interest. There's another covalent BTK inhibitor called nemtabrutinib that is a non-covalent inhibitor that is being developed. And these data were presented by Dr. Jennifer Voyage and colleagues. And here they treated 57 patients with CLL. And you can see that there are a variety of different cohorts. The overall response rate is not as impressive as is with pirtobrutinib. Again, this is cross-trial comparisons, and these are smaller numbers of patients. But again, this just points to the fact that this agent is also being developed in the management of relapsed refractory CLL. You can see here that patients who had 32 patients who were evaluable for efficacy, their duration of response once they achieved a response was not reached, compared to patients in cohort A who had received more than 2 prior lines of therapy. It was reached at about 30.9 months. Now, these data again point to the fact that unfortunately, our patients do develop progression of disease after covalent BTK inhibitors and venetoclax-based treatments. And both these drugs, pirtobrutinib and nemtabrutinib, represent treatment options for patients who unfortunately will experience disease progression. There were a different set of side effects that were seen. For example, there was dysgeusia that was seen in the use of nemtabrutinib, and again, a variety of other side effects. The vast majority of patients actually developed neutropenia, which again appears to be one of the class effects of BTK inhibitors. And so with that, I'd like to just close with a case. This is a patient who is a 65-year-old diagnosed with CLL in 2013 and was noted to have lymphocytosis on a routine annual physical exam. The white count was 15 with 80% lymphocytes, hemoglobin was 14, and the platelet count was 225. Peripheral blood flow confirmed the diagnosis of CLL. There was deletion 11q and unmutated IgV8 genes, both considered to be high-risk markers. There was no adenopathy or hepatosplenomegaly. Patient did not have any symptoms. And again, as I mentioned, if patients don't meet indications for treatment, you observe them. And then 3 years later, the patient had progression of disease and was started on ibrutinib, achieved a partial remission, but then developed atrial fibrillation when the dose of ibrutinib was reduced to 280. Now, a year later, unfortunately, 3 years later, the patient developed progression of disease and was noted to have a BTK cysteine 481S mutation. There was deletion 11q, and was switched to venetoclax and rituximab, which would really be the standard of care in that group of patients. And then, the patient had neutropenia, and therefore the dose of venetoclax was reduced to 200. And then the patient actually discontinued venetoclax after 2 years. Per the Murano data, although technically you do not really have to stop treatment at that time point, because patients who have had progression of disease and ibrutinib likely have a higher risk of disease progression. Nevertheless, this patient stopped treatment and now is having disease progression with worsening lymphocytosis 3 years later, or 1 year after stopping venetoclax. And so what would be the most appropriate treatment choice in this patient?
So the first question I have here, are there any patients, young patients in your practice that you still do use FCR? Yeah.
Sorry, go ahead.
No, just that's the first. There are other ones.
Sure.
Let me go with a series of questions.
Yeah, no, I can just start with this. So thank you for that question. I think in my practice, I've actually not been giving FCR for quite some time now. I think, although the venetoclax and obinutuzumab data with the CLL14 study really was tested in the older patient population, we have extrapolated that data to the younger patient population, and even a young, fit patient with CLL that merits treatment and desires time-limited therapy, I have gone to venetoclax and obinutuzumab as my treatment of choice. The problem, of course, is that we don't really have a lot of data to support this, but I can't imagine that the data would be any different in the younger patient population compared to the older patient population with the use of venetoclax and obinutuzumab. Obviously, you can use any of the BTK inhibitors, but again, in a young patient, 55, 60-year-old, continuous BTK inhibitor treatment is always fraught with some long-term toxicities, and I think time-limited therapy with venetoclax and obinutuzumab is really where I've gone.
Okay, thank you. Second question. In your practice, are there still patients which you're going to start on ibrutinib? Given the data we're getting now from Hatch and other data, are there still patients you're going to consider starting them on ibrutinib rather than acalabrutinib and zanubrutinib as per the guidelines?
Yeah, so I think, increasingly patients are becoming aware of, these newer BTK inhibitors. The NCCN guidelines have actually moved ibrutinib as not the preferred first-line sort of treatment option. And so in my practice, I've respected those guidelines and I've started to move away from ibrutinib. There may be reasons like, for example, insurance reasons where insurance may not approve, the second-generation BTK inhibitors, in which case I do have to use ibrutinib. But you're right, increasingly, I think a lot of us are moving towards the second-generation BTK inhibitors.
Okay. Then the next question is, what in your practice, are there any specific criteria you use in order to choose between starting patients on BTK inhibitors, which are clinical rather than just patient preference, and ven or obinutuzumab?
Yeah, so I think, like I briefly mentioned, if a patient has comorbidities like atrial fibrillation, hypertension, is older, is on anticoagulation, etc., I would avoid, using a BTK inhibitor in that group of patients. On the other hand, if a patient has renal dysfunction, I would I would prefer not to use venetoclax, although we have done that carefully, but typically it becomes a little bit challenging to monitor for TLS. And so that's really the patient comorbidities part that plays a role in selecting treatment. And then the genetic profile really, I think, is based on the presence or the absence of deletion 17p or TP53 mutation. If I see those abnormalities, then I'm more likely to go with continuous BTK inhibitor-based treatment as opposed to venetoclax and obinutuzumab. So I think those two things really play an important role in deciding which treatment option I recommend. And then, of course, the patient will tell me, well, I can't make it for weekly visits, or I can. And then that will, of course, sway my decision one way or another.
And last two questions. Do you use the MRD in your patients clinically? Do you request it, other than research, do you request it clinically and do you act on it?
Yeah. So the way I think about MRD is I get it on every patient that I use time-limited venetoclax-based treatment. And the way I use it is I will obtain the information and I think of it as a response assessment tool. So we are all used to doing scans, bone marrows, blood work, etc., to categorize a patient's response at the end of treatment. This is another test that I use to look at the end of response, MRD status. That tells me how a patient is likely to do over time with respect to PFS. At the current time, I do not change my treatment. I do not intensify treatment. I do not do anything differently based on that MRD result, except just use it as a prognostic marker and use it as an information for the patient and myself to know what to expect going forward.
So the last question, if you have a patient and you put on a time-limited treatment, let's say venetoclax and obinutuzumab, and let's say the patient progresses after 3 years post-treatment, do you re-challenge them or do you switch to another treatment?
I always re-challenge the patient with the same treatment. I haven't had a patient I can say that has reached that time point because all of these time-limited treatment approaches are quite recent. And so even if it's less than 3 years, I would always try to re-challenge a patient. I think there are data that suggests that BCL2 mutations, can be used to predict which patient may or may not respond to retreatment, but I don't think we have enough data to support it one way or another. There are non-BCL2 mutation-driven resistance mechanisms that we are slowly beginning to understand. And so I have actually gone back to venetoclax even within 6 months of relapse, and I've seen good responses. I would prefer to do that before switching treatment options.